All right, welcome back everyone, and we'll be continuing on ABIM podcast. So let's say you have a patient who has known history of heart failure with reduced ejection fraction, about 35% on echocardiography, and you're titrating the guideline directed medical therapy. So let's say the patient is on carvedilol, lisinopril, aspirin, atorvastatin, and you recently increased the dose of both lisinopril and spironolactone. And now the patient is coming with an episode of syncope. EKG is showing no P waves, but you have wide complex regular rhythm with a rate of 74 beats per minute. So why do you see these wide complex regular rhythm with no P waves? That's most likely because of hyperkalemia, since the recent dosage of lisinopril and spironolactone both were increased. This led to patients' hyperkalemia, and it is actually recommended that you have to be very careful, especially in the patients having EGFR of less than 30. So it is recommended that this combination therapy is only used in patients with EGFR of more than 30 milliliters per minute, and you have to monitor serum potassium very closely. Now, if you see hyperkalemia with EKG changes, the first thing you want to do is emergent therapy with IV calcium gluconate, which raises the cardiac resting membrane potential, and it stabilizes the cardiac membrane. Now, if you further have to continue the other therapies like insulin and dextrose, beta agonists like albuterol, high dose albuterol inhalation, which can drive potassium into the cell. Now let's talk a little bit about perioperative cardiac risk assessment and preoperative testing. Now let's say if a patient undergoes to go a knee surgery, let's say a total knee replacement, can they proceed to surgery? Now it depends on two things. So two important things to remember: that if the patient does not have any active high risk cardiac condition, and if the patient is undergoing low risk surgery, you can go ahead and do the surgery without further evaluation. So what are active high risk cardiac condition? Now, four important things: is the patient having unstable angina or recent MI? Are there any signs of decompensated heart failure? Are there any significant arrhythmias like symptomatic bradycardia, high-grade AV block, supraventricular tachycardia, new onset VT, or are there any severe valvular disease like severe aortic stenosis or symptomatic mitral stenosis? So four important things are high-risk cardiac condition. So severe valvular disease, significant arrhythmias, unstable angina or recent MI, or decompensated heart failure. So if you have these, this requires further evaluation and treatment before non-emergent non-cardiac surgery. So because these active cardiac conditions increases the risk of perioperative cardiovascular risk. Okay, so let's say the patient does not have high risk cardiac condition and the patient is undergoing low risk surgery. Now what are low risk surgery? Like for example, any sort of endoscopic procedures like upper GI endoscopy or colonoscopy, or patient is undergoing cataract extraction, or any breast surgery like lumpectomy or mastectomy. These are low risk surgery. So no high risk cardiac condition and a low risk surgery, you can go ahead with the surgery without any further testing. Now those who are undergoing intermediate or high risk surgery should be validated using prediction models such as RCRI. So now we defined low risk surgery. What are intermediate or high risk surgery? Intermediate surgeries like any orthopedic surgeries, head and neck surgeries, or prostate surgeries. Those are intermediate risk surgeries. And high risk surgery could be aortic or other major vascular surgeries, intrathoracic surgeries, or intraperitoneal surgeries. These are high risk surgery. Again, so high risk are any major vessels like aorta, intrathoracic, or open intraperitoneal. So those are high risk surgery. So if the patient is undergoing intermediate or high risk surgery, the next step is you risk stratify using validated prediction models like RCRI, Revised Cardiac Risk Index. Now what exactly is RCRI and what does it contain? So RCRI has 6 risk predictors, like for example, high risk surgery, ischemic heart disease, history of congestive heart failure, history of cerebrovascular disease like stroke or TIA, diabetes mellitus treated with insulin, and preoperative creatinine of more than 2. If you have 0 to 1 of the above risk factor, it's a low risk surgery. That means RCRI score of 0 to 1 is less than or equal to 1% risk or perioperative risk. And if we have more than or equal to 2 factors, then it's an elevated risk. So what we said right now is if the patient is undergoing intermediate or high risk surgery, next step is get RCRI. And now if RCRI is less than or equal to 1%, patient can undergo surgery without any further evaluation. If the patient is having high risk, like more than 1%, that is more than or equal to 2%, then next step is functional status assessment. So you calculate metabolic equivalents. So if the patient is having more than 4 metabolic equivalents, that means the patient is appropriate for the surgery. If the patient is having less than 4 metabolic equivalents, that means you need further testing. Okay, so let's try to summarize this. So first of all, your job is to rule out high risk cardiac condition. If patient has high risk cardiac condition, you straight away need further evaluation. And we talked about high risk cardiac conditions like unstable angina or recent MI, severe valvular heart disease, significant arrhythmias, and decompensated heart failure. So if you have that, you straight away do further evaluation and manage that first. The next thing is you look at the risk of surgery. Is the patient is having low risk surgery, intermediate risk, or high risk? So if the patient is having low risk surgery and you don't have any high risk cardiac condition, you go ahead and do the surgery. If the patient is having intermediate or high risk surgery, your next step is to calculate RCRI score. So intermediate or high risk surgery and RCRI score of less than or equal to 1%, go ahead with the surgery. High risk or intermediate risk of surgery and the RCRI score of more than or equal to 2%, then you need further assessment like functional status. So you have to calculate metabolic equivalents. You can use DASI scores to calculate metabolic equivalents. So if metabolic equivalent is more than 4, go ahead with the surgery. That means, let's say if high or intermediate risk surgery, RCRI score of more than or equal to 2%. If the patient is having METs more than 4, you go ahead with the surgery. High or intermediate risk surgery, patient is having RCRI score of more than or equal to 2%, and if the METs are less than 4, that means you need further evaluation. Now let's say you have a patient who is admitted in ICU for sepsis, who is hypotensive with blood pressure of 90/58. On examination, the patient has flat neck veins. Otherwise, labs are pretty much unremarkable. Now the patient is having AFib with RVR and there are non-specific STT changes in the EKGs. So what would you do? Would you give IV fluid bolus or would you do cardioversion? So here the important thing is to address the underlying cause. So let's say if this patient is having AFib with RVR and the ventricular rate here is less than 150, usually if the patient is having underlying reason, like for example sepsis, that's mostly the driving factor for AFib or atrial arrhythmias, and supraventricular tachycardias, especially with the ventricular rate of less than 150, are rarely the primary cause of hypotension. So here with the sepsis and flat neck veins, the best next step would be IV fluid bolus and see if the patient improves, because this can be the driving factor. And a rhythm control strategy in managing AFib and critical illness has not shown superiority as compared to ventricular rate control strategy if the patient is critically ill. Having said that, if the patient is hemodynamically unstable, has life-threatening arrhythmias, then you would treat this with electrical cardioversion. So now what are the findings of complete heart block in EKG? So complete heart block, that means there is complete failure of atrial impulses, that's the P wave, to capture the ventricles, that's the QRS. So you'll see AV dissociation, so P waves on their own and then the QRS complex on their own. And unless the patient has underlying escape rhythm, death will occur. So that's ventricular asystole. So none of the atrial complexes would be able to travel through the AV node, and if there is no escape rhythm, the patient will have ventricular asystole. And now, depending on what kind of escape rhythm it is, you can know from where the escape rhythm is. Like for example, if the QRS complex is narrow, it's usually a junctional escape rhythm. If the QRS complex is wide, then it's basically a ventricular escape rhythm. So if the patient is having narrow complex escape rhythm, you still have time to figure out. But if the patient is having wide complex escape rhythm, that means you have to do things very soon. And as we said, the P has no relations with QRS complex, that's AV dissociation. And as you would know, the ventricular rate would be always slower than the atrial rate, and it's usually less than 50. So what's your diagnosis if you have atrial rate of more than 100 beats per minute and you have P waves with more than or equal to 3 different morphologies? That's multifocal atrial tachycardia. Now, what if you have atrial rate less than 100 and different P wave morphologies? That's wandering atrial pacemaker. So tachycardia differentiates multifocal atrial tachycardia from wandering atrial pacemaker. And what is the usual etiology of multifocal atrial tachycardia? It's usually seen with COPD exacerbation, or let's say electrolyte abnormalities like hypokalemia, or catecholamine surge like sepsis. And how would you treat? You treat the underlying cause. If it's COPD exacerbation, you treat COPD exacerbation with corticosteroids and inhaled bronchodilators. And if the symptoms are persistent, or if the multifocal atrial tachycardia is persistent, then you can use AV nodal blocking agent like verapamil if that persists. Now let's say you have a patient who is coming with intra-abdominal perforation, and the previous echocardiogram showed severe aortic stenosis. And what would you do? Would you do emergency exploratory laparotomy, or would you wait for aortic valve intervention? You of course would go and choose emergency exploratory laparotomy. Now the thing we talked about for high risk cardiac conditions, like for example if the patient has severe valvular disease, significant arrhythmias, decompensated heart failure, or unstable angina, recent MI, if you have presence of high risk cardiac conditions, you should not delay emergency life-saving surgeries. So you should proceed with surgery, preferably with invasive hemodynamic monitoring to optimize hemodynamics and help minimize complications as much as possible. In contrast, if you are having non-emergency cardiac for example, if you're having non-emergency procedures, or if you can wait for non-emergency non-cardiac surgery, this should be postponed until the underlying things are fixed. So until the underlying high-risk cardiac conditions are fixed. Now let's say you have an EKG of young patient which has short PR interval of less than 120 millisecond and a slurred upstroke, which is so-called delta wave. This is typical of what? That's Wolff-Parkinson-White syndrome, or Wolff-Parkinson-White pattern. And this happens because of accessory AV conduction pathway. Mostly the patients are asymptomatic, and this can be detected on routine evaluation, but these patients are at high risk of arrhythmias, and this could be AFib or AV reentrant tachycardia, or AFib with RVR, which eventually can degenerate into ventricular fibrillation and cause sudden cardiac death. So this is why this is very important. So let's say you find Wolff-Parkinson-White pattern and the patient is asymptomatic. The next thing you want to do is risk stratify these asymptomatic patients, and this can be done using exercise testing or procainamide challenge test, or you can do EP studies to identify those who are at greater risk of sudden cardiac death. Now what you want to do with faster heart rates, if the patient is having higher heart rates, if you lose intermittent pre-excitation, that means with the higher heart rates, if you start seeing that the patient is losing the delta waves, that means that the patient has a longer refractory period, and all the AFib waves, if the patient is in AFib, would not be conducted through the accessory pathways. So patient will be having low risk of degenerating AFib into ventricular fibrillation. So for those patients who has WPW pattern and are asymptomatic, so get the exercise EKG to check for loss of pre-excitation. That means you'll have prolonged PR interval. That means these patients you can manage conservatively, but if the patient is having any arrhythmias or unexplained syncope, then you want to do EP study and radio frequency ablation of the accessory tract. Now, if this patient who has history of Wolff-Parkinson-White pattern is coming with, let's say, white complex tachycardia, and you are unable to determine whether this is supraventricular tachycardia with aberrancy or this is a polymorphic ventricular tachycardia, then what would you do? So if the patient is just having that polymorphic ventricular tachycardia and hemodynamically unstable, then you want to do the defibrillation. And the other thing you want to try here is procainamide. You want to make sure you avoid any AV nodal blocking agents like beta blockers or adenosine. So if you give beta blockers, what it's gonna do, it's gonna increase the refractory period of AV node, and now all the signals, if the patient is having AFib, are gonna preferentially go through the accessory bypass tract, and these accessory bypass tracts don't care on how much they have to conduct, so they may have very fast conduction, and all the signals can go down the ventricular route. So beta blocker, the correct way of knowing that why you should avoid beta blocker is because it's going to increase the refractoriness of the AV node, and now the signals, the atrial signals, are going to preferentially go to the accessory bypass tract. So more signals are going to go, and the patient would have a high risk of degenerating into ventricular fibrillation. Let's say you have a patient who is having mitral stenosis, especially severe mitral stenosis, which is defined as valve area of less than 1.5 centimeters square, and now this patients develop AFib. So what anticoagulation would you choose if the CHA2DS2 is 0? So the correct answer here is warfarin. So you never want to calculate CHA2DS2 score for valvular AFib. Now, the CHA2DS2 score is basically to evaluate thrombotic risk of non-valvular AFib. So if the score is high in non-valvular AFib, that's when you want to consider anticoagulants. And as of now, we know that the DOACs are better and superior to warfarin in terms of efficacy, as well as the bleeding risks are lower with the DOAC. But if you have severe mitral stenosis causing valvular AFib, the answer is warfarin. The other place you want to use warfarin as an anticoagulant these days is mechanical heart valves, or at the places where CHA2DS2 is not applicable, or if you have DOAC failure, or if the patient is not able to afford DOACs, or if the patient has antiphospholipid syndrome, that's when you want to use warfarin. Otherwise, DOACs are taking over most of the places. Now, this is also important to note that valvular disease, valvular heart disease like mitral stenosis, you need warfarin, but not for mitral regurgitation, as they think, as per the literature, that mitral regurgitation doesn't have high enough risk to be considered as valvular AFib to be treated with warfarin. Now, let's say a patient is coming with severe retrosternal chest pain, and the initial EKG showing ST elevation in inferior leads. This patient undergoes emergency cardiac catheterization, and they find acute occlusion of the RCA, and they intervene the RCA. And after 30 minutes, now you know that the patient is hypotensive, and the EKG shows minimal less than 1 millimeter persistent ST elevation, and then now we start seeing Q waves in the inferior leads. So what's the diagnosis now? Why is the patient hypotensive? So now this is cardiogenic shock due to acute right ventricular myocardial infarction. And so right ventricular myocardial infarction is seen in about 30 to 50% of patients who are coming with acute inferior wall MI, and that's usually happening because of occlusion of the RCA. Now these patients can be hypotensive, have shock, they can have elevated JVD, but the lungs would be clear, and the EKG would show ST elevations in the right-sided precordial leads, especially V4R to V6R. Now these patients who are having right ventricular myocardial infarction, so now see, the thing to understand here is if the patients who are having inferior wall MI, out of those 30 to 50% will have right ventricular myocardial infarction. So that's important to understand. So now these patients, the first thing you want to do is what? Is IV fluids. So if you give IV fluids, BP improves, then it's good. If the blood pressure doesn't improve, then you want to start these patients on inotropes and vasopressors as needed. Let's say if the patient is having mechanical mitral valve and is undergoing dental extraction, should you hold warfarin or continue? The answer is you should continue warfarin for any low risk surgical procedures like dental extraction, skin biopsy, cataract surgery, arthrocentesis, coronary angiography, or minor outpatient procedures. So warfarin anticoagulation is associated with minimal risk of serious bleeding and should be continued through the procedure, especially if it's a low risk surgical procedure. So we'll conclude here, and thank you so much for listening, and have a great day.